All right. Welcome, everyone, and thank you so much for joining us today. My name is Dan Powers, and I'm the head of business development and client management for Full Scope. For those of you joining our webinar for the first time, we host these every other month to provide our clients and partners with an opportunity to learn more about key industry trends and topics that impact the healthcare and employee benefits businesses. We're very excited for today's webinar and very lucky to be joined today by Sam Glick from Oliver Wyman, who will discuss everything else that happened in healthcare when we were focused on the pandemic. Before I introduce Sam, just a couple of logistical items. We are recording today's session, and we will send a link out for the recording following the webinar. Additionally, we hope that folks will ask questions and leverage the Q&A function at the bottom of your screen. We'll hold about 15 minutes or so at the end of the session for Q&A. So please include those along the way. So I am pleased to introduce Sam Glick. Sam is a partner at Oliver Wyman, where he heads up the firm's health and life sciences businesses globally. Sam's clients include leading providers, health plans, biotech manufacturers, employers, and venture capital firms, among others. He helps his clients create innovative solutions that provide affordable and high quality care, coverage, and financing to consumers. Sam is a thought leader who speaks at many conferences and events for healthcare executives. He's been published and quoted in publications such as the New York Times, the Wall Street Journal, The Economist, Harvard Business Review, CNN, and Bloomberg News, and has appeared on national television programs, including NBC Nightly News. So thank you, Sam, for joining us today, and I will turn it over to you.
Thanks so much, Dan, and I'm delighted to be here with everybody today, at least virtually. And, it's sort of funny to talk about everything that happened in healthcare while we were focused on the pandemic, but it has been one serious year in healthcare. Obviously, the crisis that we've had over the past year plus has been a healthcare crisis, but there's been a lot going on. And my hope is to have a conversation with this group about exactly what that looks like. But first, a kind of grounding. The crisis isn't over in COVID, and we have to start by acknowledging that. That what this kind of sine wave of outbreak and suppression is going to continue for a while. And while we're all very grateful, at least here in the US, the peak is getting lower and lower every time we have one of those outbreaks as we move forward, that's not the case around the world. Many places around the world don't have the level of vaccination or immunity that we see in the US. There are long-term effects of COVID that are going to shape the healthcare landscape, including we're already seeing health systems set up long-term COVID clinics to deal with the effects of COVID, like we've seen for other diseases. We still have political and social divides around vaccination and what it really takes to get to herd immunity. And then even before the pandemic, we had a shortage of critical care beds in this country. There's a lot of talk about how we have too many hospital beds in the US, but the reality is we have too many med-surg beds. We have too many of other kinds of beds. We actually already were short on ICU beds even before COVID became a crisis for us. So we need to keep working on that. And so it's worth remembering the COVID crisis isn't over, and that we're going to need to deal with it as a country and as people in the healthcare industry as endemic for some time to come. The other thing to keep in mind is we don't actually know what COVID is going to do to long-term behaviors. And I find this to be a really kind of interesting look on the left-hand side. If you think about the kind of major crises in the past century or so, you can think about, well, what percentage of the population was directly affected on the x-axis, and how long did it last? And COVID is approaching a duration that starts to feel like the global financial crisis that we had, and a percentage of the population, either people who got sick, had a family member who got sick, lost their job, like the Great Depression. And it's a major crisis in our history. And if I say to you, somebody is Depression era, you picture something. Right? I picture actually my grandmother who would wash Cool Whip containers and use them instead of buying Tupperware. And I picture her saving the heel of her Wonder Bread for days and days and days to make sure there wasn't a crumb left. And my grandmother did well later in life. And in fact, she saw great prosperity as they came out of the Depression, but she still was very much Depression era and had behaviors that were shaped by growing up in that era. We see a similar thing with the global financial crisis. People who got their first jobs in that 2008-2010 period to this day are still more conservative savers of their retirement accounts. They're less likely to be investing in the stock market. And it's because their habits were shaped by what that first job presented to them and the environment in which they entered the investing world and the working world. And as a result, they've missed out on a lot of prosperity. And in fact, if you look across the crises that are on here, what we see is that in particular, people who are under 30 during these periods, during the Great Depression, during the global financial crisis, during the world wars, they're the ones most likely to have their behaviors changed permanently. So what will it mean for the population that has been through COVID? Will they be more risk averse and economically conservative because they think their jobs are perhaps more fragile? Will there be a permanent shift to remote work? We're seeing businesses across the country and around the world work that out now. Will we see a kind of redefinition of employment and retirement? Meaning, well, how do COVID habits combine with gig work and the idea that somebody's going to live a lot longer? And how do we think about that? Sadly, we saw in the first 6 weeks of the COVID crisis, 10 years of job gains for African Americans erased. Will it remain kind of last in, first out? Will we continue to see deurbanization? I'm at home in California. People are moving out of San Francisco and moving into the Central Valley. We're starting to see out-migration from California and other urban areas. Will that last? Will we see more multi-generational living? Are people afraid to put their parents in assisted living or in skilled nursing, keeping them at home, given what they just saw? Avoidance of large groups, desire for smaller buildings, digital first everything, not just telemedicine, but we saw huge uptick in online shopping and other online services. New social norms. Anybody ever going to blow on a birthday cake again? I probably won't. Preference for local travel, more driving destinations maybe than flying destinations, and certainly a kind of anti-globalization sentiment, sadly. I don't have a better crystal ball than anybody, but some of these things will likely come true for some portion of the population, right? Some of these things will change their underlying consumer behaviors long after COVID happens. And so as we plan for our businesses and as we plan for how we think about an industry, we have to think about this. What does this mean for how we define our market, our catchment area, what it means for somebody to be employed, how we want to reach them as consumers, how we communicate them, how we track them. And we have to think about these behavioral changes as they come forward. On the back of this, an awful lot happened in the last year in healthcare aside from the pandemic. We saw more and bigger deals in healthcare over the last year than anybody can remember in recent memory. We saw big companies like United and Optum buy places like Landmark for home care or Change Healthcare as an enablement company. We saw Humana exercise its option to acquire the rest of Kindred, now becoming the largest home health care provider in the country. We saw Walmart just recently get into the telemedicine business, buying MeMD. We saw specialty players come into the kind of core benefit, like Centene buying Magellan, with behavioral health coming together with the core health benefit. We saw Amazon take another run at healthcare. They have one group, but they're trying to reinvent care. We saw Cigna buy MD Live. We saw CVS get into the venture business, and on and on and on. And this all happened against a backdrop of unprecedented utilization of new kinds of healthcare. At the peak of the pandemic, we saw virtual care utilization, video visit utilization, north of 70% across the country. And even as that shakes out coming out of the pandemic, we're seeing norms be changed. This chart's some great data. Vizient did some analysis of almost 27 million visits. And they're basically a quarterly view as you go left to right on the bars. And we're seeing virtual care kind of shake out. It's still much higher in primary care than it was pre-pandemic, but not at those 70+% levels. But behavioral health has stayed nearly where it was. Nearly 70% of behavioral health delivered virtually. That is fundamentally different than it was pre-COVID. Neurology, 40%, these so-called talking specialties. Well, what does this mean for not just how we engage consumers, but what the standard of care is? When you're able to do digital behavioral health, do you really need an hour of CBT, or are you better off texting somebody every day? The standard of care starts to change. Where we engage people, where physicians are licensed, how we think about a workforce, all of that changes here. We also saw funding for healthcare innovation flow in at an all-time high. We saw $14 billion in the US alone flow into digital health across 440 venture deals. Right? That is a record, nearly double what it was just the year before. We saw more IPO activity than in the last 5 years, including some very big ones. We saw funding in AI. We saw SPACs. We saw 10 healthcare SPAC deals so far this year, right? Huge amounts of funding. Now, what does this mean, right? It means we're basically in the dot-com boom of healthcare. And if anybody who remembers the dot-com boom thinks back, most of those companies failed. Most of them were overvalued. There was a lot of froth and a lot of fortunes made and a lot of hearts broken. And we're going to see the same thing in healthcare. Most of these companies will fail. Statistically, most of them will fail. But somewhere in this froth, somewhere in this milieu, there's a Google of healthcare. There's an Amazon of healthcare, right? There is the next big healthcare innovator who really wants to reinvent the system. It's here, it's coming. We're at that turning point, and we need to watch. And it may be Google or Amazon themselves as part of it. This is all happening against a backdrop of unprecedented government intervention in the economy and in healthcare especially, and costs continuing to rise at unsustainable rates. The biggest cost in healthcare is labor. Well, there are only 2 industries in the US that have declining productivity per employee, meaning when we add technology, we add labor. We don't replace labor with technology. And those 2 are healthcare and education. And we see that in the cost structures. Healthcare has been growing in terms of employment at more than 4 times the rate of all other industries over the last 20 years. And we see that reflected. We see family premiums higher than earnings and higher than inflation. And for better or for worse, this challenge is likely to be perpetuated by the amount of government funding coming into the healthcare business. We see a lot of low-performing supply that really should be disrupted, being propped up. And we think it's going to be a really interesting one to watch. The other thing is as we look at this kind of new healthcare environment, we need to think pretty differently about where the money goes. So many people, I suspect, on this webinar know the stat. It's $3+ trillion in the US that goes into healthcare. And when we think about the affordability crisis that I just showed on the previous page, that's the number we keep in mind. That's really what we think about. And if I break down that number, it's roughly 38% hospital spend. It's about 24% physician spend. It's 12+% and growing fast pharmacy spend, and the rest everything else. The surprising thing is that for the last 60 years, that number that proportion has remained mostly constant. There's actually been no change in that proportion over the last 60 years. What's happened in healthcare is we've made the pie bigger. We've made the pie dramatically bigger, but we've carved it up the same way. Now, pharmacy is growing a lot faster, particularly with the growth of specialty, and we're going to see that proportion grow up. But we have to think beyond that. And one of the things we have to think about is our view of the system is based on where premium dollars go and government dollars go, not based on where consumer dollars go. And this is one of my very favorite charts. It comes out of the National Health Expenditures data. But on the left-hand side is where the system spends its money, and those are the numbers I roughly just gave you. The right-hand side is where consumers spend their out-of-pocket money on healthcare, their copays, their deductibles, their cash. And they're spending more than 3/4 of their money on doctor's visits and drugs. By the time they get to the hospital, many of them have met a deductible or met an out-of-pocket maximum. And so the thing that we've designed a lot of our affordability initiatives around, value-based care and keeping people out of hospitals, are focused on keeping premiums down, which is great. It's really important. It's what we have to do for long-term affordability. But when we think about changing consumer behaviors, we also have to think about how they spend their own money and what it really means. And we have great anecdotes about this. One anecdote comes from Rena Shaw at Walgreens, who joined our Oliver Wyman Health Innovation Summit a couple of years ago. And Rena said that they looked at their own data from Walgreens, and they found that when a consumer's cost share for a prescription went above $50, that was a tipping point. And when it went above $50, they were half as likely to pick it up and take it home. Now, we might say from an insurance perspective, well, but that prescription costs $800, $900, right? Getting it for 50 versus 70 doesn't make that much of a difference, but it makes a big difference in terms of consumer behavior, particularly if we care about their health and care about compliance. And think about what that means. That was somebody who got their prescription called in, dutifully went to Walgreens, went to the counter, said, I'd like to pick it up. And the pharmacy tech said, okay, that'll be $65.99. And they said, no, thanks, right? Reshelve it, I'll walk away. That's a consumer behavior that we think about. Another version of this is we had a client, a health system, who took a look at these data and said, well, let's run it through our own pricing. And we said, what if a family of four is on a high deductible health plan, as is the most common now type of plan in the country, whether it's called that or not, it's above the deductible limit, and good commercial insurance, and they come in, and like happens with a lot of families of four, this was pre-COVID, a lot of families of four, kid comes home from school and brings the flu home. And then their sister gets the flu, and then mom gets the flu, and then dad gets the flu. And over about 4 to 6 weeks, everybody in the family's had the flu. And everybody has to go in to the doctor. Everybody gets a rapid flu test. Everybody turns out to have the flu and gets some Tamiflu because they caught it early. And they all share a big bottle of Tylenol. Without accounting for people having to take time off work and the transportation and all of that, the out-of-pocket on that for this system, it was a pretty typical system, was nearly $1,800 for this family on a high deductible health plan. Now, when we look at affordability and we look at value-based care, we don't talk a lot about the flu. That's a low acuity event, and it's one that we don't think about. But to that family that's making $52,000 a year and has $400 in savings, that's a very big deal. And so when we say, how do we get people to engage in healthy behaviors, we have to think about both sides. And how we create affordability, we have to think about both sides. We have to say, are we giving people the right incentives to take care of themselves and not disincentives through big upfront expenses? And are we keeping people out of hospitals, which are really expensive? The other thing to think about is it's no longer just about hospitals in the healthcare world. So many people on this webinar, I'm sure, are familiar with the term the population pyramid. And the population pyramid basically says that roughly 10% of people are nearly half of the healthcare costs, 5% of people are 20% of the healthcare costs. And the people who are driving those costs are the people who go to the hospital a lot. They're people with complex diabetes, congestive heart failure, COPD, asthma, right? The chronic diseases that we think about, and often more than one of those diseases. And so many years of value-based care and efforts at managing quality and outcomes have been focused on helping people with those diseases get healthier, live better lives, and not land in the hospital. And that's been a lot of focus. It's been a focus of some of the models that have gotten a lot of press, like CareMore. It's been a focus of places like Kaiser Permanente for a long time. The headlines that we think about, those who manage healthcare costs well. Well, with the growth of pharmacy, and specialty pharmacy in particular, the kind of stuff that you get injected, not pills you take, we are seeing a very different kind of pyramid. In pharmacy, and this is for a commercial population, so those with insurance through their employer primarily, 1% of people are more than a third of pharmacy spend in this country. And you only have to look at 10% of people to get 85% of pharmacy spend. It's a very different, very steep, it looks like the Space Needle kind of population pyramid, right? When we think about it. And The challenge with that is they have very different diseases at the top of that pyramid than we do in medical spend. The top of that pyramid in pharmacy spend looks like oncology. It looks like rheumatologic conditions. We've all seen Humira and the cost of Humira. It looks like hematology issues. It looks like immunology issues. It looks like the kinds of things where the muscles that we traditionally have to manage pharmacy cost, formulary and step therapy, that kind of thing, aren't going to be enough. And the muscles we have to manage medical costs, chronic disease management and preventing hospitalization, aren't necessarily going to be enough either. And so we need innovation here as we think about affordability in healthcare and real opportunities for those in healthcare to differentiate. Well, how do we do that? And how do we engage with people differently and think differently about what it takes to get this done? First, we got to have better data, and we got to have more coming into healthcare. When we think about what even some of the best players in healthcare have, they have electronic health records, they have claims, they have demographic data. If I'm being generous, those data capture less than 40% of the factors that affect an individual's health. And so if we're really going to engage people differently and think about the consumer differently, we've got to capture a lot more than that. We got to know what they're doing and how they're moving, their Apple Watch or their Fitbit. We got to understand how they engage online. It's an indicator into their mental health and into their financial health and into what they're doing. We got to think about their everyday interactions. We know that loneliness is a big driver of poor health. We can think about what they're eating. Right? Think about for yourself. What are the things you do for yourself that you know improve or worsen your health? Do you exercise more? Do you eat better? Do you sleep better? Do you socialize with people you care about? Do you reduce stress? Do you do things that bring you joy? Do you get out and try your hobbies, right? Those are, do you shop? Those are the, do you make sure you don't have financial stress and aren't living beyond your means? Those are the things we need to understand to really help people with their health, right? What we understand is what we do to them when they get sick. And some of the best innovators in healthcare are bringing those data together. And it's where when you look at companies like Amazon and Google who are getting into healthcare pretty seriously, potentially they have an advantage. They don't have as much at the top of this page, but they know a lot about us at the bottom of this page. Sometimes I do the experiment to say, well, what if my doctor or my health system or my insurance company could target a message to me as well as Google does? You ever get one of those creepy Google ads or Facebook ads? You know, you go online and you shop for whatever it is, fly fishing gear. And then 3 days later, just conveniently in your Facebook feed, there's a little ad for fly fishing gear. And you know they put it together, but you're not sure how. What if we could do that for good? What if we could do that for healthcare? What if we could do that to remind people to exercise and eat right and direct them to the right drugs? What could we do then? And we've got a window in which to do this. We run a survey every couple of years at Oliver Wyman, a big consumer survey about all sorts of things about how consumers engage with the healthcare system. And we ask them questions about, well, would you share health information to gain insights? And on here, the blue bar is 2020, the black bar is 2018. And we're starting to see those numbers tick down, the percentage of people who would share healthcare data. So we've got to work on this. We got to say, well, how do I demonstrate value to consumers? How do I demonstrate to them among all of these privacy pressures, I'm going to use their data for good, not for bad? The flip side of this, though, is that today, incumbent healthcare players are better positioned to take in those data than some of the big players. The big tech firms have a trust issue, and it's been the bad press about Facebook and others. And today, healthcare providers and even insurance companies are more trusted. Healthcare providers more than the insurance companies. But how can the industry use this window and use this opportunity to actually say, we're going to take in data and do things that add value to people? The other thing we have to think about in healthcare is, quote, big data. And I like data. I like big data. I like small data. I like medium data, right? And whether you call it big or not, and I have been in plenty of meetings in organizations where big data gets thrown around without a lot of definition. But the questions are starting to change. The previous questions on big data were, well, I take in more data, and that gives me a better rear view mirror view of how my business has been running. I can find the problems, and then I can throw more computing power at it, and I can get that. It's a very inside out view. That was the kind of historical business intelligence oriented view of big data. Now in this world, it's saying, how do I use data to give predictive insights first for my customers and then for me? And we're starting to see this in healthcare. Again, think about what we see with some of the very best tech innovators. That we see in parts of Google where they'll actually start preloading pages before you click on them because they can predict that you will click on them just to speed response time. Think about that. How cool is that? Right? What if we could do that in healthcare? What if we could say we have an idea what somebody's health problems are going to be, and so we're going to target the right interventions at them? What if we could take big data and even just say we can look at an insurance group who's likely to engage with the services and who's not, and we'll reach out to the ones who aren't, so that they feel we're adding value in their lives before they bring a claim and they remain loyal to us. How do we think about big data differently as we do that? If we take all of this put together, a little over a year ago, we thought through, well, so what does all of this mean in terms of kind of future truths? I'll pause here for a minute because this is a really important page. No organization can predict exactly what the future is going to bring. No organization could say, this is where the industry is going. I'm taking this bet. I know I will be right. And if anything, healthcare is going to change dramatically over the past many years. Certainly nobody predicted that COVID was going to happen last year, but many people predicted a pandemic was coming at some point. Certainly nobody predicted the kind of stock market boom that we saw and the kind of tremendous inflow of capital to healthcare that we saw in this last year, and the kind of digital health innovation that we saw. But people predicted it would happen eventually. We've been talking about the digital health revolution for a long time. Nobody predicted that we were going to see the spike in virtual care video visits that we saw last year. But there are a lot of players betting on video care for 20 years that were predicting it was going to come eventually because it was intrinsically a better experience. And I think a virtual visit is a great example of starting with consumer first principles. That no matter how good an experience, no matter how good a clinic, how beautiful of a concierge medicine practice, most people cannot get in and out of a doctor's visit in less than 90 minutes. I got to get dressed. I got to go downstairs. I got to get in my car. I got to drive to where I go. I got to find parking. I got to go up the elevator. I got to check in. I got to wait. I got to do the visit. I got to do that all in reverse. Just doesn't happen. There's something fundamentally better about 7 minutes when you get the same amount of time with the doctor. 7 minutes that maybe means 15 out of your day by the time you do the click through. And you can do it from the comfort of your home. Is it the right thing for everybody? No. But is there this kind of underlying truth that that's a better experience? And at some point, consumers were going to realize that? Absolutely. And so when we say think about future truths, what we mean is think about what are those things that are inevitable and how am I designing my organization to be ready when they come, to be ready when they're here, versus focusing on predicting what's next and predicting exactly what's going to happen when. And we would say there's 8 of those things in healthcare. One is that access will become commoditized. Today, access is a real differentiator. Today, the traditional game, particularly that healthcare providers play, was I want to buy up the right physician groups at the right locations so that I'm the only one in town because we know people go close to their home. This felt a little bit like the race for owning branches in retail banking of a couple of decades ago. And I'm gonna buy it up. I'm gonna be in the place. I'm gonna be on every corner, and if I'm there, I do it. That's what I do. Well, now in a world of virtual care, it's a commodity. I'm here at home in California. I looked online a couple of months ago as an experiment to say, well, how many places could I go for a primary care visit? And I found more than 250. I could do virtual visits through every health system in the state because doctors were licensed there, through Teladoc and Amwell and MD Live and everybody else. I could do it through Walgreens. I could do it through One Medical. I could do it through a bunch of startups. Access was a commodity to me. What was I going to pick on? I was going to pick on who was available then, how easy it was to click through to the visit. Did they treat me right? Did they make it easy? Was it a fair price? I'm going to start shopping on different things than what I have available. And that changes the model for a lot of providers who have bet on the idea that, oh, if you control that for an end, you control primary care, it'll feed the rest of your specialties in your hospitals and everything else. So you got to get ready for that truth. We also have to get ready for healthcare supply to be right-sized. Overall hospital demand is falling, ICU demand is increasing, surgeries are moving to ambulatory facilities, and at a certain point, that will shake out. Those are big fixed cost investments, but that will shake out. Am I designing for it differently? We're going to see a growth and a redefinition of home health like we've never seen before. Home health today largely means post-acute and hospice. It means the kind of thing that somebody gets after they've had a surgery, a knee replacement, a hip replacement, or they get in the last parts of their lives if they want to die at home comfortably and with dignity. It doesn't mean primary care in your home. It doesn't necessarily mean remote monitoring. It doesn't necessarily mean engaging with you on the terms that matter for you and the hours that matter for you. But that's where the money's going. United saying they're buying Landmark for $3+ billion. That is an in-your-home extensivist primary care model. That's not old-fashioned home health, making sure your knee rehab goes well. That's a model for taking care of people. Amazon Care gets much attention for the fact that it's got telemedicine, but it's telemedicine plus home health plus prescriptions. It's closing that last mile loop between virtual care and in-person care. Do a video visit, and then if you need somebody in person, we'll come see you and we'll bring the drug. That's a pretty different kind of home health. All right, that's a pretty different kind of engagement than we're used to. What this reminds me of is the difference between pizza delivery and Uber Eats. Old home health was pizza delivery. We all had pizza delivery, at least in most towns. When I was growing up, there was one place you could order pizza delivery from, and you knew their number, and they knew you, and it came out. Or if you lived in a city like New York, maybe you could get Chinese food 24/7. But that's really different than saying I can get 5-star cuisine, or I can get my favorite, corner store items brought to me in 20 or 30 minutes. And we're seeing that kind of evolution of home health. We're going to need a workforce overhaul. The average age of a primary care physician in this country is pushing 60. We have new types of people coming into the clinical workforce. Several years in a row now, we have more women in medical school than men. That's new for the US, but seems to be sticking. We have C-suites that are aging and looking for different kinds of experiences. We have people coming from other industries, from tech and elsewhere, and a much greater emphasis on empathy. We're going to need a new healthcare workforce. We're also going to need to think as part of that workforce about what artificial intelligence does and how artificial intelligence is part of the workforce. A guy named Sean Lane. Sean Lane's a great guy. And Sean Lane runs Olive AI. He used to work for the NSA, and then he turned his talents to artificial intelligence in healthcare and how you could automate tasks. And Sean Lane says that artificial intelligence isn't about replacing humans with robots. It's about taking the robot out of the human. And what he points to is good data that I've seen, is that of all jobs in healthcare, and we're now the biggest industry by employment in the country in healthcare, somewhere between about a quarter and a third of the time people spend meets 3 criteria. They're doing a repetitive task with a clear, discernible logic that involves typing, tapping, or clicking. They're doing something on a computer that you could do every day, in plain English. That's what automation is made for. That's what software is made for. You don't even have to have brilliant AI to learn to do that. You can just have regular old AI to do that. That's what we mean. It doesn't mean replacing whole departments with software, but it means, to my productivity point, taking those things that to date we just throw more labor at and saying, how can I make them an order of magnitude more productive? And how can I then focus those people on meaningful work that involves differentiating with the consumers we want to serve? In healthcare, we use privacy as both an excuse and an opportunity to protect ourselves. And that's going to change. We need data sharing in healthcare. If we're going to share the kind of data I talked about, we need to stop blaming HIPAA. and we're going to have to start thinking about safe interoperability. And financial services have paved the way for us to do this. It's still today, many EHRs in the country, electronic health records, are not talking to each other, and people don't benefit from healthcare as a system. Could you imagine if financial services was that way? Well, I mean, I wrote you a check on my bank. I'm not sure it will work at your bank. It doesn't work that way. We have industries that say we are better together. We are better because we have one set of standards, and we're going to compete on experience and ease of use and price and service and everything else. We're not going to try and wall it off because that's bad for people. We need a healthcare system that operates like a financial system, where that's not what you're competing on anymore. Genomics is changing things dramatically. Genomic medicine of all sorts is changing things dramatically. Anybody who has cancer, it's now standard of practice to look at genomic profiles and targeting drugs. We now have 50 plus drugs where we now have 50 plus drugs where through pharmacogenetics, rather than using a formulary, we can tell you whether it's the right drug for you. We had at our innovation summit this past year, Fyodor Urnov, who is a genetic medicine researcher who can do gene therapy for sickle cell and says he has 400 other diseases on the list to cure through editing genes. And then climate change. Out here out west where I am, wildfires make a big difference in terms of health. And we worry about that a lot. There's only a few hundred burn surgeons in the country. But every area of the country and of the world has a different impact like this. We see floods, we see hot weather, and it does impact global health, and we have to be prepared. So what do you do to be prepared for all of these future truths? Well, it is tempting whenever you say, well, the world is changing, and we used to do X, so let's do the opposite of X now. I've been in a lot of executive team meetings that sound like that. And the problem is, rarely do you actually need to do a 180. In fact, doing a 180 can cause a lot of whiplash and not necessarily a lot of progress. So what do you do in healthcare? Well, if I told you that the future was owning a lot of fixed assets, doing everything in a siloed local way, trying to build everything, vending a bunch of stuff, adding more labor costs, only caring about where somebody went to med school, and then praying that you could just own the customer because they didn't have a choice, you'd probably say that's a pretty bad business model, right? That's not what I'm going to bet on. But the flip side of that is not to say, well, okay, own nothing, only build scale platforms, JV like crazy, hire a bunch of people from out of the industry, replace your whole workforce with AI, only hire for people who are smiley and happy, and just try to own the data, and then people can't get loose. That doesn't work either. What we really need to do is think about a place where we're in between. There is still some last mile healthcare. Even in the peak of the pandemic, 30% of visits were happening in person. And in fact, one of the big challenges of the telemedicine innovators that we hear is, well, how do they connect to the system when somebody does need to lay hands, when somebody does need a procedure, when they do need to go to a building, when we need that ICU bed? And so we have to be asset agile. We have to think about investing in healthcare in ways that we have to think about investing in healthcare in ways that allow us to flex those assets as we go. We need to think about leasing, not buying, and designing for flexibility and thinking differently. Similarly, much like retail, healthcare is both local and national. We need national tech platforms and local agility. We know that unfortunately in this country, one of the single greatest determinants of your health status is your zip code. And that has a lot to do with the resources that are available to you. And so if I'm going to be in the healthcare business, I got to adjust for those resources. I got to adjust for the people I'm serving and the languages they're speaking and the things they want to buy. I got to embed partnership as a core competency. Most joint ventures don't work. And most joint ventures don't work because they're set up from an adversarial perspective. They're set up in terms of what are the gives and gets. And particularly in healthcare, we've trained people to negotiate for years. And everybody from the lawyers to the corp dev people to the business leaders say, well, what are we going to get out of this? This is our share. We don't start out with, how can we serve the market better together? It's not a compromise from M&A. It's how can we serve the market better together? And how do we actually train for that skill? How do we think about measuring people, not on the success of your side of the partnership, but on the partnership success and how well it's serving our mutual customers? There's probably nothing more destructive to a culture than to say we're going to take a bunch of smart people from elsewhere and silo them because we don't think most of our employees can do it. I'm going to go hire a bunch of people from Amazon or wherever and call them my innovative tech branch. We need tech competency in the whole workforce. There is no digital health. It's just health. It's not virtual care. It's just care. One of my colleagues in banking likes to tell me, he says, if you guys in healthcare had invented online banking, we'd all be talking to tellers on an iPhone. Right? That's not the potential. It's not about saying I'm going to create a division who just takes what we do offline and do it separately. I need a tech competency in the whole workforce. Everything we design should start with digital. That's what my life is, right? That's how I think about it. And people are that way. They're native. I just got to bring them in. To Sean Lane's point, I got to use AI to help employees focus, to say I'm going to make my labor investments. I got to make my labor investments in the places that actually help me serve the customer better, not that could be done by software. I got to think of healthcare as a service business. I can scale expertise. That's one of the things virtual care is great at, making sure everybody has access to the world's best specialist or diagnostician. And then I got to have somebody in front of the consumer, in front of the patient, who gets their life and can change their behavior. And then I got to use those people to earn trust every day. People do have a choice, and they have more of a choice than ever in healthcare. And fundamentally, everybody's in the trust business. So with that, Dan, I am happy to have a conversation.
Wonderful. Thank you, Sam. I do have some questions for you. I can read them if that's easier, so everyone can hear. This first one's a little long, so hold on. In reference to the slide, which compares RX costs for high-cost users versus medical, are drugs covered or provided under the medical benefit, usually in facility costs, included in the RX numbers or the medical? Frequently, the cost of drugs are reported as part of the medical data, i.e. 85% of spend is incurred by 10% of the population versus 45% of the medical cost for 10% of the population. If RX in facility are reported as medical, the cost numbers for RX relative to medical are underreported and a larger portion of the cost.
Yeah, and so in short, it's probably somewhere in between. We have done our best to estimate the buy and bill and the stuff that's bundled in medical claims, and we've been able to do that based on J codes. I don't think we have captured it all, is my guess, that we haven't pulled it out. So we are actually probably slightly underestimating the concentration in pharmacy, and as a result. So directionally, it's right, and I think it's pretty close, but it's a good point. The data aren't particularly clean.
Yeah, thank you, Sam. So I actually had a question about Haven, because that is something that sort of failed during COVID, or at least it was announced during COVID. And it strikes me that, some of the elements that you referred to earlier, particularly around the data that, say, Amazon has, would have been a part of that particular venture. And I'm just wondering if you can comment on that piece of it in terms of maybe why they failed or how that fits into some of the trends you talked about earlier.
Yeah, it's a really good question. And I haven't spent a lot of time with Haven specifically saying, well, what happened to you? But when you look at it from the outside, Haven was an interesting story. I remember when the press release came out about Haven, and that within a day, Haven destroyed billions of dollars in market value with a press release. Right, all of the traditional healthcare stocks went down. I think it was about $30 billion when I added it up on the back of a press release. And it was a one-page press release. It didn't say very much. But what it said is that Amazon and JP Morgan and Berkshire Hathaway were going to get together to change healthcare. Now, what happened with Haven? Why did it get shut down? Well, some people say Amazon decided just to take other venues for its healthcare strategy. Some say it was my point about partnerships. Partnerships and joint ventures are really hard. And those are three big companies with three strong cultures and different approaches to the market. Some say it's a matter of focus, that Haven was trying to do everything and therefore they couldn't do much of anything. Who knows, right? We will see. I think the more instructive lesson is that Amazon then picked up and kept trying, right? They keep doing pill pack, They keep doing prescriptions. You now have actually that integrated with your Prime membership. They've now launched Amazon Care. This is a consumer business and they're going after it. And so whatever happened to Haven, they got a lot of capital, they got a big balance sheet, and they're going to keep running after this.
Great, thank you. A few other questions for you. Did the pandemic highlight any successful healthcare models / approaches from outside of the US that may filter into the US model?
Yeah, the one we've seen, I don't know if the pandemic highlighted it, but we're seeing growth. Home infusion is a big one. And it's got a little bit of attention because the monoclonal antibodies that you can take if you have early COVID are infused. But most commonly, infusion is used for cancer, obviously. In Europe, for example, home infusion is a much higher percentage of the market. Something like 4x the rate of infusions are at home. In the US, we haven't done it historically, mostly for reimbursement reasons, because the reimbursement structures weren't lined up. But I think we're starting to see that change, and we're seeing growth in the home infusion space. And that's part of that broader evolution of home care, and it's worth watching.
Great. And then I think just a couple of more since we have some time. Does today's industry, which combines financial risk management competency and healthcare delivery competency, make industry disruption much more difficult? Why was risk on your slide?
I'm trying to remember the one that said risk on the slide. It doesn't make disruption much more difficult. I would actually say the other way around. I think, yes, we've seen a lot of industry consolidation, but at the same time, we're seeing a lot of disruptive innovators get really well funded and get really serious. And I actually think this sort of breakthrough we've had in terms of virtual care, with people being much more comfortable accessing care virtually, makes disruption a lot easier. It's actually pretty interesting. If you think about what it took to do vertical integration and be really disruptive even a few years ago, you had to buy a lot of physical assets. Now you can buy one virtual care player and have a national platform for care. That's pretty cool.
Right. Okay, last question that I have. Any examples of healthcare using big data, or the best examples of healthcare using big data?
Oh boy, there's lots of good examples of healthcare using big data. Let me think of a few. Where it was first used, and I think it's a pretty good one. Where it was first used is actually in fraud, waste, and abuse, and you see this across now almost all of the major payers. And it borrows from the credit card industry before that, but a really good example of kind of using big data to start to predict where there might be fraud, look across your network, save a bunch of money, and go down and use it. The other one that we're seeing, I'll give you two other ones that are pretty interesting. You certainly see it in radiology. There was a study that came out a couple of years ago that said if we really deployed big data and AI at reading scans, we'd only need 8 radiologists in the whole country. Now, I don't believe that number for a lot of reasons, but we're already seeing it be used right now to basically reduce the fatigue that radiologists have in reviewing scans by circling areas that they should pay attention to. And it does that through taking a look at big data, analyzing where there's variation, and then putting a big circle around it. That can fundamentally kind of change how the workforce engages. And I think that's a pretty interesting use of big data. The other one that I think we'll probably see more and more of is in behavioral health. That what we know is people spend so much of their lives online that the way they engage, the people they're connecting with, what they're searching for, who they're typing to, can flag when they're having a mental health crisis. Similarly, we all carry a phone in our pockets, and some of us a watch on our wrists. They can look at things like respiratory rate and what our gait is, and whether we're pacing, which can actually be a sign of anxiety. And we've already seen startups like MindStrong is a good example, which Tom Insel, who was at the National Institutes of Mental Health, helped to found, where it's don't call us, we'll call you behavioral health. They literally have an app on your phone that takes in all the data, analyzes it, and points toward when you might be having an anxious moment. And then your phone buzzes and a therapist talks to you for a few minutes. I think we're going to see more and more of that, and it's a pretty exciting time.
Very exciting. Okay, we do have one final question that just came in, Sam. Can you talk about the cost of telehealth or virtual care versus in person? This person highlights that the charges have notably been similar or remain the same, and theoretically should be lower cost of care for virtual. So, can you speak to that, or has that been your observation?
Yeah, it's the observation. We're in a tricky spot. So there are two sides to that argument. Fundamentally, the cost should be lower. You're not having to rent a building. It's more efficient for the physicians and for the staff. You don't have to have a waiting room staff. You don't have to have somebody to get people in a room. It is less expensive to deliver the same service virtually, full stop, from a cost perspective. There's an argument that was made that in order to encourage health systems to pivot to that kind of virtual cost structure and to make the investments that they needed to get there, that you had to give them reimbursement parity. That if you suddenly started saying to health systems, well, we're going to pay you less for that, and to physicians, we're going to pay you less for that visit, then you would never have gotten them to cross the chasm and to actually make that investment. This was similarly the argument that was made during COVID, and CMS famously came out with reimbursement parity, was that, well, if we don't pay for them at the same rate, then health systems and doctors are going to have bad incentives to bring people in for visits that might be less safe. And in fact, we want to make the incentives the same. We've seen this now in 6 states with commercial reimbursement parity, including big places like California and Florida, effective this year. The problem with that is it's a drug. Reimbursement parity was theoretically intended to be a temporary measure. Let's get you over the line, but then we should be able to dial back reimbursement in order to realize the advantages of the underlying affordability. And I'm afraid the results on that have been mixed. It depends a bit on the state, but the traditional systems, I think, are still billing pretty much at typical rates. Where you find the more affordable visits are in the pure play startups, the Teledocs and Amwells of the world, who will do a telehealth visit for $49, $59, $69.
Great. Well, thank you, Sam. If there are no other questions, then we'll wrap it up. Sam, thank you so much. That was fantastic. Really appreciate your time and fantastic insights into the market. Again, folks, thank you for joining. We will be sending out the link to the webinar, so stay tuned for that. And we'll look forward to seeing you again in a couple of months for our next webinar. So thank you.
Thanks, Dan.
Thank you.